Are y'all ready to start? I'd like to welcome everyone to the quarterly Board of Health meeting. We've been engaged in strategic planning, a process that we're going to be engaged in twice a year at the board's request. And it's a very productive morning. Public health has a lot of things challenging it, and the importance of the work of the Department of Health is critical in maintaining our state's health. And this board plays its role as part of the team. And I appreciate their presence here today. Before y'all leave, if you want to read Bobby Moody's a resolution which we had approved the last time at the last meeting, it's complete. And if you want to read the entire resolution, we're going to give it to him hopefully in January. We can get him here. If he can't get him here, we'll present it to him in person. And I'd also like to recognize and state we appreciate the chairman of our Senate Public Health, Hob Bryan, who is a champion of public health. Will we be giving him that a little bit? Why don't we do our opening prayer first? And we'll bless it, Hob, before we get there.
Well, bless me while you're blessing.
We will. With Bobby Moody gone, I'm going to ask Dr. John Davis, you think you can swing our opening prayer, and then we'll do the Pledge of Allegiance. If everyone would please stand.
Father, we come to you now with gratitude to the members of this board, and particularly for the extraordinarily hardworking people of the State Health Department and the tremendous work that they do to promote the health of Mississippians. Lord, we pray that you would be with us, that you would cause us to have sound judgment in the decisions that we make today. And we pray that you would keep us safe until we're back together again as well. In Christ's name I pray, amen.
Thank you, Dr. Davis. Everyone would turn to the flag. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. You may be seated. Should we go ahead and present that to Senator Bryan? Senator Bryan, you're very special to this board. We admire you and respect you and appreciate your contributions to the protect and advance the health and well-being, safety of everyone in Mississippi. Sometimes you're considered a little eccentric. I don't know if you know that. And you haven't. But we always appreciate your brilliant sense of humor and your extraordinary intellect, as well as your genuine ethical commitment to the state. That is quite admirable, and you were a public servant of the first order. And this board and this department presents you its 2025 Public Health Champion Award. And we'd like you to be the 2026 Public Health Champion, the 2027 Public Health Champion. As long as we're here, we want to give you this every year because you will deserve
You
it.
haven't said anything about 28. That's a year of some concern.
We'll see how you do in 2027.
You and 60,000 other people.
Thank you, Senator.
Do I get to say thank you?
Yes.
Thank you.
You can actually make other comments if you'd like. What are you thinking?
I appreciate it very much, and I'll say again, I try to make every meeting of this board that I can because I always try to listen to people who know more than I do and actually know what they're talking about. I appreciate the opportunity to attend, and I appreciate each of you being willing to serve on the board, and I appreciate this.
Thank you. And thank you again for your service. The first item on the agenda is the approval of the minutes of July 9th. Yes, July 9th. Yes, I'm lost in October, it looks like. The approval of minutes from July the 9th, 2025. Have y'all had time to review those? Are there any corrections? And if not, is there a motion to approve the minutes?
Mr. Chairman, I so move.
There's a motion and a second. All in favor, say aye.
Aye.
Any opposed? All right, now we are at Dr. Edney's report. Dr. Edney.
Thank you, Mr. Chairman, and just to let the board members know, Chairman Creekmore also is very faithful to attend your meetings, but he is in Washington today, advocating on behalf of New Albany, Mississippi, but also on public health, and was in conversations with me about things to communicate to the delegation, so we appreciate him being up here. And if you remember, we're having to award Chairman Bryan today because he was absent at the last meeting.
That's because I'm an airhead and we're trying to keep that quiet.
But we are so proud of both of our public health chairs, the House and the Senate, are such strong supporters of public health and the work of this agency, and very supportive of this board, and we are very grateful for that. Austin, go to the next slide. All right, well, today we have with us from our EMS Bureau and three important members and employees of our agency who were instrumental in helping us with the planning and carrying off the EMS Memorial dedication, which we did a couple of weeks back. It was extremely well attended. We had over 100 people who attended, many of family members from those who are being recognized on the monument itself were in attendance. We were very proud to have the governor as our keynote speaker. I had a nice reception afterwards, and I just wanted to recognize Christy and you and Christy Berry, Courtney Day, and Edwin Mitchell, if y'all would stand and be recognized. Thank y'all for the hard work and all that you're doing in EMS. Also very proud, Lauren, you and the comms team were extremely helpful in carrying the day off. And it was, Mr. Chairman, you were here, Dr. Carlton, you were here. It was a good day for the health department that day.
It really was.
What encouraged me the most was when I had a family member who was talking to me and said, Dr. Edney, I wanted to make sure that they were pleased. And all the family members were very pleased with the ceremony, but with the memorial itself. And the comment that I'll always remember is, Dr. Edney, I feel like we've been seen and heard today. And so if the families were pleased, then I'm pleased. So good day here at the health department. All right, I also want to remind everybody that this is Breast Cancer Awareness Month. Krista, guys, you're here. And Krista, stand up, Krista. You don't have Amy here.
It's on another meeting.
Okay, Amy Gibbons is the director for our breast and cervical cancer program. Krista is over women's health and has responsibility over that area. But we just want to remind everyone the importance of breast cancer awareness and the importance of the BCCP program, because it is an opportunity for every woman in Mississippi to have breast cancer screening. And so we take care of the uninsured and underinsured women to give them opportunities for mammography, but not just that. We don't just give away free mammograms. We are providing comprehensive breast screening and evaluation. So if the mammogram is abnormal, the program will pay to work up the abnormality. And if, God forbid, we do find breast cancer, then it facilitates enrollment into Medicaid very quickly. So it is a wonderful program. It does not get enough attention. And so I'm very happy to highlight Krista and Amy's work and everybody in that program for all the good that they're doing for especially the women of Mississippi. And you have in front of you a breast cancer awareness pin and pink ribbon to take with you. Krista, thank you so much. All right. very pleased that to let you know that we have had a very busy few months since July, and it's always interesting at the health department. It's been interesting and challenging very recently, but we continue to move forward in accomplishing the mission. I've been very pleased to be part of the Rural Health Transformation Grant work group that is extremely impactful for helping to transform rural healthcare throughout the country, but the work that it will do in Mississippi, and the governor's office is leading that effort, but we're very proud to be at the table with them and the Division of Medicaid as we are putting the application together working with all the stakeholders throughout the state. I'm just really excited about the opportunities that we have for rural healthcare in Mississippi. Very busy working on the infant mortality work that we have had. Awful lot of attention as we have been working to get our arms around the escalating number of the infant death rate for our state, and very pleased with the partners that we've been working with. We'll talk more about that under Dr. Cheney's committee report on maternal infant. Let's see, Tanya here?
Yes, sir.
Hey, Tanya, stand up, please. I want to introduce to you and to the public Tanya Rahilio, who is our new director over what we're just calling now health services, but there is a robust reorganization going on with what has been in the past health services and preventive health into looking towards directing all that work towards population health improvement for the areas that are the program areas that fall under that. Very proud to have Tanya on board and part of our executive leadership team. So Tanya, welcome. Glad you're here. Thank you. All right. And as chairman, we will take the legislative session report. Logan, we will put that under Mr. Hubbard's report for his legislative committee. And at this point, I think we can move on to Creative Tribune CFO report. And is Dr. Dotson here? Oh, there you are. Okay. Let us do the Creative report, and then we'll backtrack to the EPI report. Ms. Tribune?
Okay, the slide that you're seeing up on the screen now, want to go through and just give a brief overview of our 2027 budget request. We are requesting level funding for 2027. For fiscal year 2026, which we are in now, our total general fund appropriation is right at 61 million. And so to continue operations for the upcoming fiscal year, we are requesting level funding. And on the screen, you can see the breakdown between the various buckets from our trauma care to our core public health programs and our appropriated amounts, which are pretty much flow through for other purposes. Last board meeting, we touched on some of the capital central campus improvements. And so I wanted to give another update on that as well. As you probably saw, we have a lot of construction projects going on campus. From last board meeting to now, you can see a tremendous update on the pharmacy warehouse, which is in the center of the complex. The estimated completion, we're almost done with that, is expected to be around December of 2025 for completion. And if y'all remember those, that project is being funded by our fund. Next, I wanted to mention the elevator modernization project for our garage. As you probably saw coming in, excuse the construction, but we are getting elevators replaced so we can be ADA compliant and have more updated equipment. Other items on the capital improvement plan that is coming up. We have the Thomas Lab envelope restoration, which will be starting in March of 2026. This building, the Osborne roof envelope, it has been substantially completed, but there are other parts, other phases that will begin in the upcoming year as well. And also, we are looking to continue to improve our campus. Are there any questions from the board in regards to the level funding request proposal for 2027 and also on any of our capital improvement, campus improvement projects? Okay, that concludes my report.
Thank you, LaCree. We're very excited about the improvements on campus. We're in an aging facility, and this building is much younger than the Underwood building is. So we're very grateful that we had the opportunity to renovate the historic buildings on this campus. Central Campus is extremely important to the history of public health, but very much to the function of public health. So we take the stewardship of the state's property here with our campus very seriously, very happy to be working with DFA, the state of Mississippi, on these projects. I will ask Dr. Dotson to come forward and to give you an epidemiology update.
Good afternoon. I've got found slides going on over here. It's a pleasure to address you all. And I usually start when I talk about epidemiology in the news. And what has remained in the news for us, unfortunately, is pertussis. As you can see here, the reported cases began to increase in 2024 nationally and both here in Mississippi as well. And in Mississippi, the number of pertussis cases reported in 2024, if you see there, the next to the last bullet point was 49, which was comparable to the number of cases reported in 2019, which was at 54. But that was higher than the reported cases in 2023, where we only had 3. So fast forward to 2025, and we have shown a continued increase in the number of reported pertussis cases. So that last bullet point represents 120 cases for this year. And sadly, we've had one pertussis-related death in an infant that occurred in September of this year.
Dr. Dodson, what happened in 2007? Why was there such a spike that year?
I think nationwide, we saw a spike that year too. I don't have the true causation for what happened here in Mississippi.
All right. I was just wondering whether there was something similar occurring that's happening.
You were on the Board of Health then.
Yeah. I think there was an outbreak in North Mississippi among unvaccinated individuals.
An outbreak there. So the next slide is just, you can see the epi curve over the course of the year for our 2025 cases. It looks like we have a little spike about every 2 months so far this year. And then as of October 7th, we had 120 pertussis cases that have been reported to us here at MSDH. And of that 120 cases, 95, which represents 79% of the cases, occurred in those who were less than 18 years of age. So if you look at those first 3 bars, that accounts for 95 of the cases, and those are in individuals 18 years or less. And then 12, or representing 10% of the cases, occurred in those who were less than 2 months of age. So that first bar. Of the 109 cases with a known vaccination status, 58 or 53% of those cases were not vaccinated. And that is represented by the orange, by the yellow section of the graph. And of the 58 cases that were not vaccinated, 50 of them, which represents 86%, were less than 18 years of age. This next slide also shows the cases by district. So the majority of our cases that occurred in 2025, which was 70, the number 77 was 64%, they occurred in 3 districts, in districts 2, 5, and 9. District 2 alone accounts for 33% of the reported pertussis cases. And then finally, West Nile has been in the news a bit lately. This year, we've had 30 West Nile virus cases that have been reported. 23 of those, or 77%, were considered neuroinvasive, and 7, which represents the remaining 23%, were non-neuroinvasive. The cases, the ages of those infected were 28 to 91 years, with a median years of 69 years of age. There were 3 West Nile deaths reported during this year. They were in Hines, Madison, and Washington counties. And in comparison to years past, specifically last year, there were 59 West Nile cases and 8 West Nile deaths. I'll entertain any questions.
Roxanne, can you remind me where District 2 is?
District 2 is
Sorry.
up in the northern part of the state, Lee County, up around that area.
Thank you.
Dr. Dodson, usually the worst West Nile occurs when the mosquitoes are most active, so in the summertime, right?
So we
And late.
actually had a milder
So
season.
we had a pretty mild season.
Yeah, this pertussis is a significant concern for public health nationwide. We're all seeing throughout the country the increased numbers in whooping cough. What's very alarming this year is I know Louisiana has had 2 infant deaths and Kentucky has had 2. I don't know. I talked to my colleague in Alabama and Arkansas, Georgia yet, but we've not had a pertussis death since 2013. So it's disturbing. We're having infant deaths related to vaccine preventable diseases, but this case bears out why community immunity is so important. The infant was too young to be vaccinated. The family was vaccinated. The mom, as we understand it, was vaccinated or boosted during pregnancy. But somewhere in the community, a case with pertussis got close enough to the baby to cause the infection. And, we are working on the pertussis campaign communications. As I don't know if you have seen our messaging related to grandparents, making sure that, especially new grandparents, if there's a newborn in the home, making sure that everybody is boosted. And just reminding everybody, when you get your tetanus booster, go ahead and get, your triple component with diphtheria and pertussis all at one time so we can keep our community immunity up. We do really well with the children, but then not so much with adults. The adult vaccination rate really drops off. So we're working on that messaging, working on messaging to providers to think pertussis. Anybody can get pertussis, but it's most impactful on the babies. So the best way we can protect our babies is for all of us to keep our immunity up as much as possible. And please, please, please don't be around babies when you're sick. And be careful. Don't take sick babies to nurseries. They're just some common sense issues. Any other questions on epidemiology? Any of the Dr. Dodson updates me every Monday morning on what's going on out there. There's always something.
Any questions?
Thank you, Dr. Dodson. We appreciate your work and the work of the EPI team. The chairman, other high priority issues, the government shutdown has kept us busy, but we are okay. We were very pleased. WIC is the biggest stress component on having to cover any lack of federal funding, but we did get direction from USDA allowing us to access our 2025 budget year money for WIG that should carry us with operations through the month of October. But we are committed to taking care of our WIG participants and this, especially our priority one new enrollments, which are pregnant moms, breastfeeding moms, and new infants, that we will continue enrolling that. And, we have contingency plans working with USDA so that WIG remains in operation throughout the shutdown. And at this point, we are okay with our workforce, and we are just anxiously waiting for resolution to occur in Washington. And at this point, we're monitoring everything going on there, but just want to reassure you and our employees that we are okay. We have the funding to cover payroll and to keep our programs operational. And I believe our contingency plan will be effective so that we don't have any shortfall until the shutdown is over. And Mr. Chairman, that is our State Health Officer report for this meeting. Questions?
Any questions for Dr. Edney? We appreciate your leadership and the department's leadership during this
Thank you, sir.
difficult period with the shutdown. All right. The next item on our agenda is our consent agenda. It's actually a very long agenda, 14 items. Consent usually means there's nothing controversial. If you would like to discuss any of these issues, I would ask you just to request that an item be extracted. Otherwise, we'll approve them all as one. The first item I'd like to extract, which is governing the licensure of child care facilities. The regs are not quite finalized, and this needs to be referred back to the committee. So are there any other items that y'all would like to be extracted? If not, if I can have a motion to approve the consent agenda, which would be items 2 through 14, and extract item 1.
So moved.
There's a motion, there's a second. All right, any further discussion? If not, all in favor say aye.
Aye.
Any opposed? All right, the item number 1 is before you, and I'd like would like a referral, a motion to refer this back to the committee for a finalization of the regulations. Is there a motion?
It'll go back to program area to work with the Child Care Advisory Council.
Then I move to do what Dr. Edney just
I
said.
second.
There's a motion and a second. Any further discussion? All in favor say aye.
Aye.
All right, very good. That's most of our work outside of committee reports. Why don't we start with maternal and infant health? Our vice chairman, who is chairman of maternal and infant health, Dr. Cheney, can you update us on that?
Sure. Continue to meet quarterly, and our last meeting discussed two things very important, and it is the, although I tend to refer to it as maternal health, it is maternal infant health subcommittee, and so we did discuss the infant mortality crisis, and I suspect that Dr. Edney will want to make some comments about that. And we also discussed the ongoing development toward implementation of the OB system of care, and which is falling into place. But is this when you wanted to talk about the infant mortality crisis?
Sure. Okay. Thank you, Dr. Cheney, and I really appreciate the supportive work that your committee is doing to help us with our work in the agency. Austin, if you'd move to the infant mortality section, we have in front of you this folder that has the slides in it. And just very quickly, want to review with you what we reviewed with Dr. Cheney and the Maternal Infant Health Committee. This graph here tells the story of infant mortality very nicely going back to 1950. And the top pink dots are the Mississippi mortality numbers for the babies and going all the way back to 1950. The green dots below that are the U.S. numbers. And you can see 1950s through the mid-70s, there was wide separation between the mortality numbers in Mississippi compared to the U.S. average. And then you see in the latter part of the 60s, those numbers come down very nicely and keep coming down into the early 90s. And I remind people that is not because of improved neonatal care in NICUs. That's because of vaccinations coming online and really knocking down the number of vaccine preventable deaths that we were seeing in infants. If you go back to the 1950s and early 60s, we were losing 2,000 to 2,500 babies a year. And those are staggering numbers. We're down to around 330 to 350, which is severely high numbers, but nothing in comparison to what we were looking at prior to vaccinations coming online. One thing I want you to look at is as we move into the 2000s, it just starts to plateau. And then if looking at go to the next slide, Austin. This gives you a more amplified picture going from 2000 to 2024. And you can see the separation between us and the U.S. average. But what is very concerning is that despite a lot of hard work from so many people, we continue to maintain excessive mortality rates with the babies. Thankfully, it doesn't look like 2007 did when it was 10.49 deaths per 1,000 live births. But in 2024, we saw the rate go up to 9.7. And I'm going to let you go to the next slide. And this shows you demographic breakdown with the babies. In the top left corner is relates to our African American mortality rates. The top right corner is Caucasian, and then Hispanic mortality down in the lower right. But what's most disturbing to us is if you look over the last decade, if you look at maternal death, you see trends that are moving in the right direction. But when you look at infant death, we do not see those same trends. In fact, over the last decade, we see a trend upwards. Now, it's not a steep trend upward, but looking at the last 10 years, that line is going the wrong way. And when you look at 2024, as we were seeing those numbers coming in, Dr. Young and her team, Sam Miller, were alerting me that the numbers were not looking good and the numbers were worrisome. And we studied those numbers for a solid month, knowing that, we'd be reporting that to the CDC, and basically the CDC just turns around and sends out the state data. And is trying to understand why our mortality rate, went up to 9.7 per 1,000 live births for the entire population. And as we were just drilling down, unfortunately, the African American infant mortality rate is really what is driving things. And what's very worrisome when you look at the African American infant mortality, you see that we were running 12.7, 12.1, 12.3 per 1,000 live births the previous 3 years, kind of flat, and then a jump to 15.2. And 15.2 is a staggering number. It's a number we can't ignore. It's a number we can't just write off. It's the worst mortality rate we've seen in the last decade. And again, with the trend moving in the wrong direction. We actually saw, as you can see in the top right corner, some improvement in Caucasian deaths, small amount, but we're still above the US average. So none of our demographics are doing great, but we have particular problem in the infant mortality space for African Americans. And so knowing, and the next slide also will show you, this is the heat map for infant mortality for the state with a 5-year aggregate. And it shows you where the problem counties are. And so a 5-year aggregate is, helps to eliminate any fluctuation trends. But you can see our core Delta counties are of particular concern, and our core southwestern Mississippi counties are of particular concern. We're doing best on the Mississippi Gulf Coast, but I would point out to you, we should be, Dr. Brooks, 5.4 per 1,000 live births, US average thereabouts. And you can see in the best area of the state, we're still a full point above that. Seeing 7.4, 7.2, and coastal counties, 6.2, 6.5, and that's our best numbers. So it's, we have problems all over the state, but especially we have difficulty in the core Delta and the core southwestern counties. So we've been working with the Division of Medicaid regarding our premise program, which is what people know our high-risk maternal infant programs have been in the past. That was rebranded to Healthy Moms, Healthy Babies 5-6 years ago. And working with the Division of Medicaid, we are just trying to work together to better deploy the limited resources that we have to improving our infant mortality numbers. And so we have for you, go to the next slide, Austin. So one thing I'm a big believer in, we have problems every day, and usually Chris has to bring me the problems that I have to deal with. And I know by definition, those problems are all the easy and moderately difficult problems have been dealt with before coming to me. So when we're looking at complexities at this level, just stating problems is not enough. We need to be looking at solutions. So I wanted to review with you, not just the problems that we're seeing, but what we're doing at the agency and why the agency public health emergency is going to help us. First and foremost, as Dr. Cheney said, is the OB system of care. His committee has been working closely with us through that. Very proud, Teresa Wyndham and Christy and the team in the acute services area of the agency working with Mississippi Healthcare Alliance. We have come a long way, but we need to move faster. Looking at these numbers, and we need to be deploying solutions in 2026 rather than 2027, just because of the way our numbers are going. So the agency emergency declaration will allow us to work faster in construction of the OB system of care. It allows us exemptions from personnel board procurement, some state personnel board issues, and with ITS to move through the construction phase much more quickly, which was really my top concern, that we get the OB system of care operational in first quarter 2026 instead of quarter 4 or first quarter 2027. And the emergency declaration is helping us do that. We plan to have rules and regs moving steadily to Dr. Cheney's committee for vetting immediately. And Dr. Cheney's committee is aware that a lot of regs for review are coming. And we have work groups with leadership in place for maternal levels of care and neonatal levels of care. Dr. Rachel Morris, maternal fetal medicine at UMC, is leading the maternal level of care work. And Dr. Randy Henderson, neonatology, is leading our neonatal levels of care work. And so our first step is to have that built out from a regulatory framework to bring to you for your January meeting. And I'm optimistic that if everything moves as they should be able to at this point, then we'll be able to come out of the January Board of Health meeting working with hospitals to implement the designated levels of care. That is a big deal. That is a huge accomplishment for our state. It is getting a lot of attention nationally, and ACOG keeps checking in with me. Dr. Cheney, where are we with our designated levels of care? The other states are talking to me a lot about this. I've had multiple opportunities and invitations to present on the OB system of care because it is a novel approach to maternal and infant mortality issues. What we are seeing with infant mortality is improvement on the maternal side in terms of deaths. But the fact that we're not seeing improvement on the infant side, there's a direct correlation between maternal health and infant mortality. So half our babies are dying in the first month of life. That is chromosomal abnormalities, which we can't do a whole lot about. But then the rest are preterm low birth weight babies. And there is a lot that we can do with that. The OB system of care will help make sure our preterm low birth weight babies are getting to NICUs faster. Hopefully it will help high-risk mothers deliver at higher levels of care, so we're not having to move sick babies, that they're being born to where there is a NICU, and the OB system of care will help us in that. But we have to be working to improve maternal health. We have to improve the health of these pregnancies that are generating these preterm low birth weight babies and help those pregnancies mature from 22 weeks up to, if we can just get them to 27 weeks, our outcomes will improve. If we can get them to 30 weeks, they will improve greatly. And the way we're looking at doing that, bullet 2 is closure of the access gaps for perinatal care, basically elimination of the OB deserts in the state. Now, I will push back on many who want to define an OB desert as a county without an obstetrician. That is not true. We're really looking at pregnant women in Mississippi who are more than 40 minutes away from prenatal care. Now, we have a lot of counties that don't have an OB, but they have an FQHC who's providing perinatal care. And then we have counties that have family medicine doctors providing perinatal care. But what we did in 2016 with Medicaid really doing a nice job covering our moms and babies was to pull back from the county health department perinatal system to allow the private sector to do its good work and our FQHC partners to lead. But what we have seen since then, we do have counties that there's no one else there. There's no FQHC providing care. There's no family medicine doctor or OB providing care, and they're 40 minutes away from care. But the one thing that is there is a county health department. So in those select counties, now we're studying that. Dr. Dotson has jurisdiction here through her Center for Public Health Transformation through field services. We're currently determining what counties we need to plug. And so we're not going to be plugging holes where there are OBs. We're not going to be plugging holes in Sunflower County because family medicine OB is there. We're not going to plug holes where FQHCs are working, but we're going to plug holes where no one is working. And we'll do that through the county health departments through using our mid-level providers to provide prenatal care and postpartum care throughout that whole year in coordination and collaboration with their OBs. The first thing when we diagnose pregnancy will be to, if they're not on Medicaid, is do presumptive eligibility and get that turned on. And we're already doing that. And then we will immediately do the risk screening and connect them with an OB. They need to have an obstetrician over their care, and then we will collaborate with the OB. Talking with OBs in the Delta 2 weeks ago, Dr. Dotson and I were told that if we can pre-package our pregnant moms, they are full so far in advance that they may not be able to get in the first trimester. They welcome us coming in and taking care of things in the first trimester and alerting them of things we're finding, get the lab work done, get their risk screening done, get their ultrasounds done, so that first visit with the OB, they have everything they need. And then if it's a mom that's 2 hours away, then we'll help Dr. Cheney and his colleagues manage them if they're having trouble getting to the clinic on a schedule, and just us all work together. And by my definition of what a true OB desert is, when we complete this project, there will be no OB deserts in the state of Mississippi. We will have all the areas of the state covered, mainly through our private providers, our FQHC partners, and then us being the safety net. Bullet 3, and y'all stop with any questions you have. I'm just trying to be respectful of your time. Bullet 3 is to leverage our community health workers, which are now recognized by the state and certified by us, and changing the Healthy Moms, Healthy Babies model from nurse home visitation to community health worker home visitation, which is much more cost effective. And also CHWs have better access into the homes that we need to be helping than the public health nurses we're having. The public health nurses will be in the clinics working in support. Krista Gines and her team working on the redesign. It will be much more sustainable and I think scalable. And we're working with the Division of Medicaid in partnership there. But home visitation is extremely important in this space to reduce maternal health issues. But we think the new model will be more effective for us. Bullet 4 is to make a hard push on the accidental deaths that relate to lack of adherence to safe sleep principles. And we are working with community partners and through the Healthy Moms, Healthy Babies program and through our county health departments to distribute cribs for safe sleep for homes the high-risk homes that need them. But as we deliver a crib, it will also be with delivering safe sleep teaching and making sure the home environment is safe. I told you half of the deaths were in the first month. The other half are older than a month, and a large number of those are accidental suffocations and strangulation from co-sleeping. And that's low-hanging fruit for us to help reduce those accidental deaths. But we will be continue to push harder with car seat distribution and get back into the crib distribution business. And then we have Lauren Hegwood and the comms team is currently developing a statewide educational campaign related to safe sleep and continuation of the grandparents campaign. Because one thing, it's not just making sure grandparents have their pertussis boosters done, but a lot of grandparents have a lot of oversight of the grandchildren. They're caring for these babies in their homes and making sure that the grandparents know the safe sleep principles and that they have a safe crib for that baby to sleep in. And then looking at the success that we all had in COVID vaccination distribution, we were successful there and eliminating that health disparity where when you look at the mortality data, African-American mortality is lower than Caucasian mortality. It's one of the few things that we can see that with. And that came through working with community leaders, community partners to understand the problem of their communities better. We're not going to figure these problems out from Jackson. The problems in the core Delta counties, why women aren't engaging in prenatal care early. We're not going to solve that here in Jackson. We will solve that by working with our partners in the Delta communities and Southwest Mississippi communities. So really just leveraging the lessons we learned in the pandemic that were very effective, as you well know from your leadership through those years, applying that to our maternal infant health and mortality work. And I do believe we will see dividends come out of that. So, Mr. Chairman, the emergency declaration helps us, we will be, we're able to buy the cribs, in a matter of weeks instead of months and get those out. It's allowing us to build an OB system of care much more quickly. It allows Dr. Dotson, I saw you were needing some exemptions from the nursing board for your program that helps us there. So extremely helpful in the work that we're doing. This will not be enough, but I think it's central to the effort. These are the things that we can do. We have the resources to do, and really a lot of this only we can do. And that's where I think we need to put our focus is on the things that the Department of Health needs to be doing. And then working in cooperation, partnership with community partners in the other spaces. I've already had a high-level meeting with the FQHC leadership about this, with the leadership at the Public Health Institute about this, and we have more community partner meetings that we'll be doing as we work to try to improve the problem with our infant mortality numbers. Happy to entertain any questions.
At the very beginning, Dr. Edney, you mentioned some people I want to double up on, Teresa Wyndham and Christy McGregor and the Mississippi Healthcare Alliance and how they're working with the OB system of care.
Yes.
They're doing a lot of good work there. I do have a question about on the mortalities in the counties and so forth.
Yes.
Is where the mother lives what establishes the county or?
It does.
Okay.
Not where the baby's born.
Right.
Where
One reason I was asking is I was noticing there was no value in having a major hospital because those counties are about equal with all the other counties
Right.
as far as the number of deaths.
Right, so, we don't have a shortage of birthing hospitals, we really don't. And they may not be exactly where we would like them to be. But the number is adequate for the number of births we have per year. We do not have enough OBs, which is why it looks like we may have 2 family medicine OB programs coming online, that extra 4th-year fellowship for family medicine, which will be very helpful. And we're hoping that 2 licensed certified nurse midwife programs will come online, one at UMC, one at Mississippi State, because we definitely need workforce. Workforce is part of the problem.
And community health workers, how about the payment for them now? Where do we stand with that?
Yes, sir. We're working with the Division of Medicaid, and we're looking at some options that we want to be very careful with the Medicaid budget, which is why we're looking at a pilot project between us and the Division of Medicaid. And if it involves Medicaid reimbursement to us, we will pay the match, which keeps Medicaid whole. So it's not an at-risk issue for the division's budget as we work the next couple of years to figure it out. We're also looking at opportunities with some federal funding that may cover the pilot project and just take our time to see what's the best way to look at reimbursement for community health workers. And so the division of Medicaid's been a really good partner with us with this.
Thank you.
Dr. Edney, on
Yes,
the
sir.
figure 7, just following Dr. Waits' question about that, what is the gray county? What is that?
0.
What, 0 what?
That no infant deaths. There weren't any births from those counties.
So there were not, those were counties in which presumably there was a mother.
We don't have mortality rate.
There was not a mortality.
There was not a live birth that represented from the county, as I understand it. Is that right, Sam? No infant death. Okay,
Because if the
No.
counties are for where the mother is,
correct.
okay, so.
And if there's no infant death, then the mortality rate is 0. And if you see Mr. Perry, those are all real low population counties. So what we're not doing, we won't have a nurse practitioner. In some of these counties, there may be 3 pregnant women in the whole county. But they have access trouble. But we're not going to have 5 days a week perinatal care in those counties, but we will rotate around to cover. We'll have CHWs working and with those families, and then we'll either transport them to a level 3 clinic close by, or we'll have a rotation for the mid-levels to go through that county on a certain schedule.
Can you say one more time your definitions? But OB Desert was no more than 40 minutes away from,
If they're more than 40 minutes away from perinatal care. And if you look at the definition of not having access to an OB, then half the counties are deserts. If you look at 40 minutes or more away from perinatal care, that number goes down. Doesn't go down to 0. It's probably going to get down, Dr. Cheney, 10 or so. We're studying it. Dr. Dodson's going to tell us. But, what we're needing is someone who's closely overseeing the pregnancy with an OB. If we had to virtually part of the time or from a distance, there's no way we can close the deserts by plugging OBs in these counties. It's not possible.
And rural citizens are kind of used to driving a little while, to seek care.
We
I think
do.
most of the OB cares.
We do have some
Regional.
counties that are 2 hours away from care. When you look at Esquina County, there's some counties that are a long way from care, and that's really where we need to put our attention is when we're at an hour or more from care, then we need help.
and presumably when you're looking at that, you're looking at Alabama, Tennessee, and Louisiana, Arkansas. Well,
Yes, sir.
so if you're on the river, you can.
That's right.
And if you're in a small ER that doesn't have an OB, we have an OB system of care, we can get them where they need to go very quickly.
But Dr. Cheney's group actually plugs some of Alabama's desert, don't you? The folks in West Alabama come over to them, so they're serving those kids. That's a very good point. Sir?
Bless them.
Oh, bless them, yes, sir. And we work to help Dr. Cheney's group, get Alabama Medicaid to finally start paying them.
Other questions?
No action items from the committee, Mr. Chairman.
We had looked at vaccinations and the role they play. Are there any racial disparities with vaccinations? Does that play a role?
No, sir. Actually, it's again a reverse disparity. The African American population, our minority populations maintain a high vaccination rate.
Very good.
So what was the point then of number 6 on your action plan?
So that was to take those lessons learned from how we figured out, if you remember in the early days of the pandemic, we had that low vaccination rate in our minority communities and mortality rate was really going up. And then, the approach changed from just doing mass vaccinations to continuing doing that, but finding out why minority communities weren't accessing vaccines and listening to them. And we had to do some things like, move it to church parking lot, move it to this part of town, in this Hispanic community, getting the National Guard not to be in uniform, things like that.
So when you're going back to number 6 on your action plan, it's less about, you're not trying to address a vaccine disparity. You're just trying to talk about how to address other disparities.
That's right, yes, sir. Using the success of eliminating a health disparity and applying those lessons to infant mortality.
I guess instead of mimic or vaccine, it should be
It is.
mimic our.
Our vaccine, I apologize. It's to mimic our vaccine equity success.
All right, what other questions we have? Anything else? Dr. Cheney, what else from your committee? Anything else?
Looking forward to getting all these regulations.
They're coming.
Get ready. All right, very good. Excellent report. Our legislative committee, Mr. Hubbard, we were going to get Logan maybe to present.
Yeah, we conducted our meeting on September 30th, and Dr. Eddie and Logan Dillon presented the 2026 legislative proposal to the committee. I think it included 9 different items, and Logan's going to present that. And after he presents, we're presenting this as a recommendation from the committee for the board to adopt.
All right. Mr. Dillon, the chair is yours.
Mr. Chairman, appreciate it.
Okay, so these are the 8 items that are on our legislative agenda for this year. First one is our yearly uniform controlled substance law. Every year that we are tasked with conforming the state law with the federal uniform controlled substance law. And this year we have 3 different items. As you can see, they're all scheduled and related.
This is a normal thing we have to do every year. This is the list given to us.
The second item is to continue seeking funding for the Underwood building and other capital projects. So far, we've received $14,750,000. The last 2 sessions, we received $4 million, so we'll just continue to ask that those projects be funded. The next item is every year we have asked for the revolving loan fund, the rural water revolving loan fund. This year, the request is $8,967,000. And that's a 5-to-1 match. So if we receive that full amount of support, it'll be $44,839,000. Okay. The next item is we're seeking a increase in the fee structure for food inspections for the Division of Food Protection. This will help, that's the current and proposed fee structure. This will help fill a $1 million general fund gap that is currently used to fund that program. Doctor, do you want to add anything?
That this is doing this kind of work is how we're able to achieve level funding by closing these deficits, the programs that should be fee-based.
And you had said the stakeholders in this are very supportive. Great.
Next item is we're going to seek a specialty car tag this year. And the first step in that project process is we need to get authority from the legislature. So that is the design. And this year we'll be bringing that before the legislature. And not doing anything on that.
Just a process we have to go through.
Every Mississippian should probably get one.
Okay. The next item is we're going to seek allocation of a small portion of the medical cannabis revenue to be deposited into the Mississippi Public Health Trust Fund, which was established in Senate Bill 2729 in this past session from this year. The next item is after the passage of House Bill 1062 last year, some of our work for dental hygienists was interrupted when some language was removed, and we're seeking to have that language put back in, and that is the language itself that we're going to be asked to put back in this year.
And this is the previous exact language. We're just dropping it back into the bill that was revised last year. And it was not meant to impact our work. It's just unintended consequence of we've done as much administratively as we can with the dental board. So we had to put the statutory language back in.
And the final item is from our Red Health Division. This is to ask for a exemption from the Mississippi Public Records Act for relating to radioactive material and radiation producing devices for safety purposes. And Dr., do you want to add anything on there?
Yes, this is just right now through public records request, anybody can get the location of where these licensees are. And it's being brought to our attention that the radioactive material or the radiation producing devices that are legal and licensed and we oversee can be repurposed for more dangerous reasons. And so I think we need to follow the lead of other states that this is information that should not be available to the public that would cause a potential terrorist to go to the location of this material or devices. And it just, I think it would be an appropriate exception to the Public Records Act for the safety of the public.
Mr. Chairman, that's the full legislative report.
Thank you. Very good work. Mr. Hubbard, your committee brings this forward, correct? For a vote. So since it's brought forward by a committee, it does not require a second because there's more than one board member on that committee, and a second is implied. So all in favor of our legislative agenda, say aye. Any opposed? All right, the ayes have it. Thank you.
And see if you want to make comments.
The last committee is the CON committee, which I chair. We are preparing our recommendations for the legislature. We discussed some of those in our strategic planning. We anticipate 2 more committee meetings, one with HMA advising us, and we'll try to have prepared our list of recommendations for our public health committees in the legislature before December 15th. And we probably have a special call Zoom meeting by the whole board to review those before we submit that. But I anticipate a little bit more work there. Any questions about CON? All right, with that, we're at old business. Any old business that the board would like to bring up? All right, if no old business, is there any new business? All right. We do have an executive session.
We don't
We
need
do not. All right. We may get through before 2. Very good. You see the appendices that are included in our packet. Our next board meeting is January 14th, 2026, and we have next year's, you can see those dates, put them on your calendar. I do want to thank Chairman Bryan for being here. Your presence is always very critical. Would you like to say anything to us before? Yes, very good. The floor is yours.
At the risk of overstaying my welcome, one of the concerns that I have had is an overarching concern, not merely with public health, but other places, is the failure to look comprehensively at problems, and we get off in silos and don't do as well operating here, yonder, and there, as if there was at least some coordination. That led to the language which gives the department the authority and the challenge to comprehensively look at healthcare in the state. And in listening to the approach about dealing with perinatal care, did I say that right?
Yes, sir.
So many words. But looking at what's going on the ground and looking at what's actually being provided, regardless of where it's being provided from, looking carefully at how you would define a desert, and we could argue forever, but I think it's clear that in many areas, although we collect data by county, that's overly simplistic and on and on and on. So I say all this to say that appears to be an example of what I keep trying to talk about. And just briefly following up on that, we have right now opioid money, and we've got opioid money here, opioid money at cities and counties, and there are people dealing with opioid money. Then we have the rural health application. We've got a group of people dealing with rural health, and then we have legislative appropriations and on and on and on. I worry that that's not being coordinated, and regardless of the decisions that are being made or who makes them, everybody would benefit, I think, from working together to make sure you can amplify what each other is doing. And finally, something that we overlook that I think is useful in a number of areas is the advantage of the flexibility that the private sector has. There are situations that come up where it would be nice for X to happen, and for a lot of fairly good reasons, it's very difficult for the government to step in and do X. If there's ongoing coordination and communication with private foundations and others, this is a thing that you private foundation could come in and do. You can do it quickly. You can do it without being fair. And there's so much synergy or whatever that's involved with just the cooperation. So that's an ongoing concern, and I'm proud to see that taking place, and that's one of the things I think would be good to do in the future. That wasn't too long, was it?
No, it's perfect. And the board is very much sympathetic and engaged with trying to help y'all coordinate the care of essentially the public health needs of the state through this department. And we do feel that's the natural place to coordinate most of that care. So we're willing to help you accomplish that. And thank you again for being here. And thank y'all for being here. If no other comments, Dr. Edney, is there anything else that you need? Is there a motion to adjourn?
I'm so moved.
The deed is done. See y'all in January.
Thank you.